the Department of Medical transcript?
No, we don't have. So we tried, so it doesn't really worked. I mean, we haven't, it has really hasn't succeeded, you can say, in that sense. In the sense we feel that may not be a big need for that in our place. So the only thing where we may need transcription is for sending the letters. So most of the doctors prefer to write it on their own, give it immediately, than calling on the phone, you know, giving the dictation and taking it back, correcting it, sending it.
The first observation is there is a center in the CMC Vellore which is called the South Asian Cochrane Center, and they believe in answering any query relating to evidence-based medical
Practice.
details. So I suppose most of you are aware of the center. You can make any query. I think they were talking of the evidence-based medical factors. You can make any query and get your query answered by the Cochrane Center, and we have an ongoing collaboration with that, number one. Number two, this question is, sir, for you, I mean, a clarification. What kind of a training or updation of information is there relating to the biomedical equipment, the knowledge relating to the biomedical equipment, the costing aspects, etc.? Because this is one area where I think the knowledge that is available in public systems is, I'm sure, it needs to be substantially stepped up. So how are you trying to keep up with whatever is happening in terms of manufacture, in terms of maintenance, in terms of taking care of the maintenance of this biomedical equipment and upgradation of the existing equipment? I'm sure you must be buying a lot of equipment.
Yeah.
So how do you build in clauses relating to the upgradation of the equipment as and when new versions come up?
You know, one is today the finance may not be a problem, but from LICO they have developed a tool. If somebody wants to buy a new equipment, whether it's sustainable, whether no, after 4 or 5 years when the lifetime of that equipment is over, will they be able to buy on their own? Today somebody may donate an equipment, but 5 years down the line whether they'll be able to buy that equipment. So they have developed a tool wherein people can put the data and see whether it is sustainable to have that or not. But we'll see.
No, basically, I think whenever somebody wants to go for an equipment purchase, internally we have a process. So it is usually, if it is a replacement, I think there's less scrutiny in the sense they just have to justify that the whole machine is not usable. No, it's like condemned. No, we can't use it. So it's less this thing. Suppose they want one more of the same machine, then they have to give a workload justification. No, that as to why it is required, either because they added a new floor, so we have another machine. So there's got to be some rational this thing. If it is new technology, like a LASIK machines, a completely new thing being added, then they have to do like a financial justification. So it could also be free patients. In the free patient, money may not come in, but you put in a notional revenue. So that, because I think finance is a good way of actually bringing all your service into one platform, and then you can make sure that whether it is able to pay back within 4 or 5 years' time. Or conversely, it will also give you what kind of patient load is required to justify that equipment. So that's the discussion that we have. So sometimes we will say, okay, let's look at it next year. So that's the kind of thing we do as far as technology is concerned. And of course, there is also some subjective element to it, because as a teaching institution where you want to attract good talent to come, we also want to be a bit on the cutting edge. So that is another thing where there's some subjective assessment is also made. In terms of ongoing equipment maintenance, I couldn't get the person in charge to come. It's my mistake, I couldn't contact him on time. We have a very rigorous maintenance protocol. So every equipment there is a cycle. Most are covered every week. So usually Saturday also there will be some kind of dusting, cleaning, oiling, depending upon the equipment. And so every equipment goes through that cycle. And we have an in-house team just to go back a bit on that history, when we first started, we never had any maintenance people. And I became the de facto technician. No, I was administrator then. So I used to be actually taking care of all the problems, and then I will get woken up at night, 12 o'clock, sir, the heating coil in the sterilizer is gone. No, so at one point of time it got out of hand, and so I decided I must get someone else to do this work. So I started the equipment maintenance division. So put in two technicians, and that's how we started it. And then over time we found that that department became really useful to the hospital, because we had so many surgical instruments which were going to throw away, kilos of them. And once we had these people, and then they got trained in resharpening, reconditioning the instruments, we literally put back to use several lakhs worth of surgical instruments, which otherwise would have been just junked out. So that department became quite a prominent department in the institution. And then about 15 years back, we said that every hospital should have such a department. So we started offering a training program. It's a 6 weeks training program on instruments maintenance, and it is one of the, it's offered 4 times a year. We take 6 to 8 candidates, and it's always full. Now, it's a very popular course, and in fact, I recall in the very first course, one of the participants was from Karnataka RIA, from Minto Hospital, a guy called Phillips. He was there, somehow the government saw the wisdom in sending that person, and then he went back with the training. So in this training, the students not only get the skill in instruments maintenance, but they also get a complete toolkit. That is all that they require to do the routine maintenance. So these people, after the training, will be able to provide the first line maintenance for instruments, know what to do, and more importantly, know what not to do. No? In the sense, we tell them they cannot open up the optics of a microscope or a slit lamp. No? So they get that kind of knowledge, and then when to call a outside manufacturer to come and repair it. So they get good inputs on that. So this has really helped us to almost ensure 100% uptime of our equipment. It is quite seldom that you will find. So in fact, when we do this training, we don't have enough broken equipments to train these people. So every course, we organize a instruments maintenance camp, something very novel. We will write to somebody in, we've gone even to Chhattisgarh actually. Now we write to the doctors, they're saying that we'll come and do everything free for you. Now you collect all the instruments and keep from your hospital or from your other people in that area. You only pay for the train fare. So we've done a number of camps outside states also, where you take these people, they'll be there for about 4 or 5 days, and then the 100, 200 equipments will be repaired and fixed as part of the training. So that's something which I would really encourage every hospital to invest in. Yeah. And this person can be anybody, so it doesn't need to be a formally designated position. No? So we had electricians come, we had some senior nurses come, sometimes drivers come. No, there's always somebody who's got that mechanical. Everybody, I think everybody of you will have somebody in your hospital who is doing this thing for you. No, that person can be formally trained for about 6 weeks. The tinkerer in the thing, yeah.
I had raised this issue because I think in public institutions, not many of us maintain logbooks relating to the utilization of the equipment. I do not know if you are doing it, I'm very happy. But if you are not doing it, I would request you, urge you to, and commend to do this. I was the managing director of the health corporation. I tried my best to do it in government hospitals. Probably my tenure was too short to do that, number one. Number two, there is no serious effort in updating our knowledge, in taking on board the technicians who are available, in sending them for periodical trainings as Mr. Tulsiraj has said. So it's absolutely essential. We buy equipment worth crores of rupees. It lies underutilized. I'm sure if you maintain a logbook, the utilization of equipment in public institutions is not going to be more than 40 to 50%. Do you agree? It's not more than 40 to 50%. For want of technicians, for reasons which are totally inexplicable, the equipment is not used in public institutions, not so much perhaps, I don't know, in ophthalmic institutions and big general hospitals, the equipment is not utilized. So it's an issue which certainly is an area of concern. I would request that we start looking at it, try to address this in whatever manner that we are capable of, update our knowledge, develop a sense of upgradation of these machines. A lot of companies are are legally mandated to provide you upgraded versions as and when there is an upgraded version which is available. It needs to be built into your procurement procedures. It needs to be built. You need to take the help of people who are competent. I'm sure Aravind Eyecare is one institution where probably their help could also be sought.
Instrumentation audit also, instrument audit.
Yeah, that's
That
right.
take place because there are many suppliers who just supply the instrument and run away. They don't give you actually the required services. I'll just share my one experience. We had two Leica microscope, 680 and the 840, 619, 840. And number of times the suppliers were changed, and so the regular service was not coming, and the instrument become idle after 3 years. That was in 2002. From 2002 to 2006, the instrument was not being used or used very in minor kind of cases because of fungus or deterioration in the optics. In 2006, we finally had to write to the Swiss embassy to look into the matter, and then the Leica people came and changed those optics. Again, the supplier got changed. The instrument is lying idle. Again, we have approached, and now finally they have agreed to replace one of the microscope, to make operational one of the microscope for at least 4 years of their life, so that the 10 years of total life is covered.
So I can give one piece of advice to everyone, something which we have learned the hard way. Unfortunately, for most of the advanced equipment, India, we still have to import them from Japan, Germany, Switzerland, US, whatever. And those people don't find it maybe worthwhile to have their own establishment here. I think, except for Alcon and Allergan, nobody else is. Zeiss has come in more recently. Yeah, so otherwise they always had number of dealers. No, they'll have a country dealer, and then those guys will keep changing. So this exactly happens when you buy from imported manufacturer. The local dealer after 1 year is their own relationship soured, so they quit. So they totally forget you. So you don't have anywhere to go. So what we do now is for any imported equipment, we get an undertaking from the original company that they will maintain it in the event of the current dealer thing going away. For everything we do, like for example, telephone exchange we bought from Siemens. There is one guy in Madurai who is, they say he's our dealer. And we know, looking at the guy, this guy may be gone in next month he may be changed or he may go. And it doesn't look like an established company, but this is no, you have to go through them. Then we said, sorry, if that is the case, we have to give an undertaking that we will deal with you in case this guy is changed. No, so that has become a standard practice now, so that, and they will do it. And you have this power only till you place the order and place the advance. Once you give the advance, you are their slaves. So I think you have to build in all these things up to that point. No, so we do this. Second thing we do is we kind of negotiate the AMC. So after you've given the advance, AMC is what he decides. Till you sign the check, you can decide the AMC amount. No, you can say it can be 4%, 3%, whatever it is. So you make all those negotiations before you release the order with the advance check.
While ophthalmology is something about which I cannot talk much, instruments and equipment is something I know very well because I've been an engineer and a maintenance engineer. The first point of maintenance of any equipment is the user. If the user can only clean the dust on the equipment, see that the wires are not loose, the voltage fluctuations in case it uses electricity, necessary equipment are there. These are all very simple procedures which a user can do on a day-to-day basis. It's true for a diesel locomotive, it's true for an ophthalmic microscope. The driver has the primary responsibility of maintaining his locomotive. So, it significantly drop when it is most of the equipment maintenance comes out of dust, friction, rubbing, sticking up, the screw not going in, coffee spilling on it, whatever, etc. So I would emphasize that the user will have to take that, and then the system should be to all the other things you say. I certainly take it, but this is something I would recommend.
Exactly, that's why works for 8 years, 10 years in a private system, whereas you can say 1 year time and response. Yeah.
So sir was saying if there is a manual, it will be useful. We actually have a very good instruments maintenance manual along with the DVD. Huh?
It is there.
Videos with the DVD. It's available. I think very soon it will also be available online on a very much like a tutorial. You know, you can log in and say, how do I change a bulb in the slit lamp? And it will give you full instructions, you know, for doing that. So that will also be available very quickly. And the manual and the CD are available even today. It must have been displayed at that, yeah.
And also if at the state level, if they want to have an instrument maintenance workshop, we can organize it. We can send out engineers from here. For each state, you know, you can choose one place where they can bring all the equipments, and we can also not only repair them, but also train some of the people. So it's possible. So we have done it for the whole Pondicherry, all the government hospitals, GH, local medical colleges, we have done it once. So any other issues you want to discuss? Yeah, on the last presentation, any questions? We call that like a parameter review.
I'm just curious. I think Haripriya or Ravi earlier on presented about this cataract outcome monitoring. No, wherein today we are feeding in data from our own network of hospitals, and then you get this benchmark. You know where you stand, and it is anonymous in the sense for those who log in, they will know only their hospital data, and then the other comparisons. The average and who is the best. So would there be any interest amongst, because this came up I think yesterday's discussion, we should somehow monitor the cataract outcome. So I see one hand up.
How the data will be uploaded into that?
Just like we are uploading, from just like we are doing. No, this is a cloud application. Yeah, like that. Yeah. So this can be accessed from anywhere in the world. No? So I see two people may be interested. Yeah, okay.
The challenge is mostly on collection of data, designing a form to capture the information and then entering the data into the system. You have to do that pre-operative, intraoperative, after the surgery complication, and the patient comes back for follow-up. So all that, So it has taken us quite a while. But Ms. Tulsi was also suggesting that we can do it like a 6 months on-holding, hand-holding process to work with, somebody is interested. It may not be just one-time process. So we have to help you in designing the forms, how to collect the data, how to capture it, and then how to use the data once you have collected that information for analysis, like what Dr. Haripriya showed. So it has to be like a complete thing. So it may take like a 6 months process of interaction to set everything on, to make it usable. Yeah. So they are the challenges actually. Yeah. Work on that.
I think the HOD you can have some influence on that.
Yeah.
It's not already part of your HMIS data?
If you have HMIS, only good HMIS.
I think it's used in group data will be
Not that nice one.
but detail
data for the auditing purposes is not adequate most of the time. Because we need at our level customized software at our own level and maintain.
If someone is working on a specific disease, naturally he'll have a little bit of data and analyzed kind of thing. Otherwise, the general data is not analyzed.
Present HIMS under NPCB, which has started from January 2012, there we have to only tell the total number of cases and the types of surgeries that we have done. Other details are not there on it.
Yeah, the summary data is usually available, yeah.
But ma'am, is there any review process in your hospital, in CMC?
Like I was mentioning yesterday, we are the Sentinel Surveillance Unit for the NPCB.
Okay.
And we have to send information to them every month, every 3 months, whole year.
Okay.
So actually we use the SSU forms to upload the data. They give us the, what shall I say, the software and what they want us to do for it.
Okay.
But we use that also for our own hospital system.
Okay.
The challenge has been, I didn't raise that question because I know what the challenge is and what the answer is, but I can't implement it, is to make sure that that data is entered.
Okay.
So very often, at the moment, a registrar's responsibility to make sure that that data is entered on the computer. Not happening because obviously they're very busy. So what happens is the charts are pulled out from the MRD for the incomplete charts and then updated.
Okay.
So if the entry person is not identified, I am not so sure if you can help me with that I have to fix. But we look at it regularly. In fact, now every monthly meeting, we discuss what was the outcome, who were the patients who had poor outcomes, was it from pre-op or post-op,
Okay.
and then we act accordingly. So we are doing it, but our systems have to become more robust to handle it.
Here, yeah. So for example, the pre-operative and the surgery data are entered at the time of surgery. Once the surgery is over, it's part of the MRD, the medical record department. They have a person who's in the operating room, they'll enter the data. Similarly, in the ward, we have a ward secretaries, they'll enter the data. The follow-up, we have the coordinator in the cataract clinic, they enter the data. Or
So
Dr.
we are
Haripriya?
also running this SSC unit with us.
Huh?
We are also having a SSC unit, Sentinel Survey Unit of Government in India with us in our institute. But luckily I could sustain my data entry operator with me. So it's easier for me to cover the regular entries and upload them at time to time. Okay. And second thing, one of the faculty members look as a coordinator for the community work, and the same person monitor and supervise this thing, whether they called as a CSR, cataract surgical records, goes in time. Similarly, the state government takes in monthly information, as you said, sir, the logbook for the equipments with the different category between 1 to 5 lakhs, 5 lakhs and above, and 10 lakhs and above. How many patients, the turnover we have. So we are submitting it monthly, and it's a checklist for us also. Similarly, the surgical and the medical IP and the OPD. There's a regular information is going through the director to the rest of the authorities for the further analysis.
Okay.
We also have a data entry operator and faculty looking at it. The bottleneck is actually filling the form. How do you deal with that? Who does that?
Registrar only. And similarly, parallelly, we can check it through the ward records and randomly through the theatre records.
Yeah, you design a form so that it becomes easy to fill the form also.
For monitoring, we don't have the filling is distributed, but then you have someone monitoring it.
Yeah.
Yeah, so we have also software built up to pull out the gaps. Yeah.
So the software, yeah. You see.
The department itself, each department will have a log of them checking it.
Otherwise you cannot do this. Huh? Yeah. Anything, any other comments? Any other issue? No, just to go back this infection control, I would like to make some certain remarks. So recently we have spent a lot of money for infection control in this hospital. So close to about, still now probably we have spent about 1.5 crores in this last 18 months so that we have less infections. So where we have spent this money is on the sterilization systems. So earlier we didn't have this one-way sterilization route. So today we have seen those 2 autoclaves where we have 2 doors and it is controlled by a vacuum pump. These 2 machines cost about 35 lakhs. Okay, the earlier thing we have scraped. There are 2 autoclaves which cost about 5 lakhs each, about 10 lakhs. We have taken that off, we have put these machines. So then we have put a reverse osmosis water system which feeds all these autoclaves because they also say the steam quality is also important, and also for washing the hands, washing the instruments, equipment, we also need a good quality, sterile and also water free of all the salt. So there we have invested about 10-12 lakhs. And then we also replaced our ETO machine that has got a printing mechanism, what all has happened, everything. And then we have developed a system for the ETO processing, whole processing the way, so that there is no mix-up of sterilized and unsterilized. That is where many cluster infections all happen. And earlier we used to have a tape, sterilization tape only in the bin. Okay, we know that this bin has been sterilized. Today every patient on the case sheet we put a sticker, sterilization sticker. So now by each set of instruments, today we've got 600 surgeries, each set of surgical set will have a label that it has been autoclaved, with who autoclaved it, what set, what is the time, all that. That we put it also on the case sheet. So across, and then we also have invested on a dedicated laundry system for the operating room. Earlier it used to be a common or a manual washing. Now for each operating room, we have got 3 operating rooms, each one of them we got a separate laundry system. So we got about 7-8 lakhs for that. So across all the hospitals we have spent large amount of money. So we feel that this something like this will help in reducing infection. So we strongly believe that changing the gloves may not contribute to that. It is much more easier. Or giving a pair of dress to the patient to change may not cost us so much of money. But we have put the money where we feel it will make a difference. So it's also on the long term, it will help us. So if it becomes a mandatory, the government says that every case you have to change, we'll change it. But today that pressure is not there, luckily. But if there is a government regulation comes, this is how it has to be done, we'll follow that. But till that point of time, we don't see any benefit in doing that. But we make sure that the doctor, the nurses, everybody puts that scrubbing solution between the surgeries. Even the circulating nurse, anytime they have to open that bin, they have to open a sterile set, they have to put the thing. So we have got a lot of processes in place. So with that, that note, I'll close the session. I would like to thank all of you for the participation. Thank you.